Gretchen, and Gretchen will be over. Thank you, Stacey. And Gretchen will be over able to share the screen and do that. We'll have a presentation for the next, I'll say, 40-45 minutes, and then some Q&A. Please use the chat box if you wanna ask any questions, or unmute and we can hear you, and you can ask the question during the Q&A. My name is Leopoldo Cavazza. I am the director of the CMHSR, the co-director of CMHSR, along with Byron Powell. And it is my pleasure to be here today to introduce our great speaker and postdoctoral fellow about to finish her fellowship. And so we're very excited about that. And this is our last CMHR seminar of the year. We'll have a new seminar series starting in September in our next academic year, and we're excited to do that. So today we are very fortunate to have Dr. Gretchen Buchanan, our NIMH T32 Postdoctoral Scholar at the Center for Mental Services Research here at the Brown School, who is like a week from moving on from the fellowship and going into the real world on her new academic position. We're super excited about this. So a little bit about Gretchen. Dr. Buchanan is she's a co-investigator on a 2-year pilot study funded through the Washington University Implementation Science Center for Cancer Control. The title of her project is Let's Start With What We Know, a mixed method assessment of practice-based implementation strategy for addressing behavioral health in primary care. She's interested in improving access to high-quality behavioral health services through intervention in primary care, with a particular focus on mental health equity. She received her PhD at the University of Minnesota while studying the implementation of integrated behavioral healthcare, parent-child relationships, and preventing parenting program. She's also she also has a clinical MA from the University of Nevada, Reno, and a BA from the University of Portland. Gretchen is also a licensed marriage and family therapist and a licensed alcohol and drug counselor. And today we're so excited for her to present practice-based implementation strategy for integrating behavioral health in primary care, preliminary results from our pilot study. So welcome, Gretchen, and we are so happy to have you here and looking forward to your presentation.
Thank you, Dr. Cavazza. Hello, everyone in the room as well. I'm just going to get this shared. Stacey, can you allow me to share my screen?
Hold on. Gretchen, did that work?
Yes. Okay. All right, everyone. Can everyone see the slide? Can you see the slide? Okay, great. All right, so today we're going to be talking about practice-based implementation strategies for integrating behavioral health in primary care, which is long, but I'll talk through each of the constructs as we go. We're mostly going to be talking about the methodology that I'm using because I have results from our first clinic, not completely done, but done enough that I'll talk through some of them. We have more clinics to go and more data that we're analyzing, as well as continuing data collection. So you'll get a taste for what that's going to look like as well. So first, let's talk about what is integrated behavioral health. It is typically defined as kind of augmenting the primary care medical team with a behavioral health professional, so be a psychologist, SW, something like that, and seeing patients for kind of this brief. They usually see them kind of same day, and usually they kind of have a mix of either like scheduled patients and then what's called like a warm handoff, which is basically a provider sees a patient. The patient either has like a high score on a depression screener, or they talk to the provider about having some kind of health concern, and the provider pulls in the behavioral health clinician to see the patient and kind of give them this pretty focused intervention, or kind of try to do some more diagnosis, or just kind of assess what the situation is. They can function as a bridge to specialty care, so they might see the patient on wait list. Oh, everyone on the call, if you could mute, that'd be great. And so a lot of times these days we have wait lists everywhere for therapists, and so they might function as somebody that can help kind of get the person stabilized until they're able to get in somebody, which might be a month or two away. So they might see them every week, they might just see them once. They might just see them as needed until they can get there. And they can also, they do a lot of kind of support and education with the primary care providers to kind of build their skills and their confidence in being able to address kind of mild mental health concerns, and kind of giving them more education so that they feel comfortable dealing with those and asking questions. They also often will kind of develop new workflows in the clinic as well that kind of build the capacity of the clinic to provide mental health services, screening for mental health issues, and then providing those services. So let's talk a little bit about what are the different components of integrated behavioral health. So this looks like a lot. I would just kind of focus on the upper kind of rectangles there. So these are 5 principles, and then on the right side there are 9 structures that are needed to support an integrated behavioral health program in a clinic. And there's a couple different models for integrated behavioral health. The 2 most common ones are called the collaborative care model, or COCM, and primary care behavioral health, or CBH. And they're very different models. So the collaborative care model is very structured and usually involves a team that's the primary care provider, behavioral health clinician, who's usually like an LCSW or someone like that, and then a psychiatric provider. And so what the psychiatric provider does is, instead of kind of the typical model where the primary care provider might refer somebody that needs psychiatric medication to a psychiatrist, they actually remain the prescriber, and the psychiatric consultant kind of does chart reviews and consultations with the other professionals, and kind of does an evaluation of the chart and of what the primary care provider and the behavioral health clinician are telling them, and they give recommendations. They give some education to the provider. They give recommendations for kind of a treatment plan, and so that kind of provides some backup and some consultation for the primary care provider. And this model is typically used to kind of fill the need of like a shortage of psychiatric providers, and so the consultant can actually see a lot more patients than if they were seeing the patients actually by themselves and having to schedule those hour-long visits, every month or something like that. The primary care behavioral health model is more psychotherapy focused, and so it's kind of just a generalist position, and it tends to be more like kind of what I was talking about earlier, where they are available for handoffs, they develop workflows, they provide that short-term care, and so that's kind of a no wrong door, everyone, they basically see everyone in the clinic, anyone who needs any kind of behavioral health support, whereas the collaborative care model is a bit more focused. Usually they have like a registry, which is like a list of patients that have enrolled into the program. So sometimes those models actually are implemented in the same clinic because they serve different functions. So the one is kind of based on a shortage of psychiatrists, and the other one is based on kind of a shortage or difficulty accessing psychotherapy, or just that the people are presenting with a need for psychotherapeutic services in the clinic, and the providers don't know what to do or don't have the skills to be able to fully address it. And so So why integrated behavioral health? Why would a clinic want to do integrated behavioral health? As I'm kind of preaching to the choir, but there's a mental health crisis in our country right now. There's millions and millions of people with untreated mental health issues. Only about half of people are actually getting the services that they need. There's a lot of mental health inequities, and there's groups of people who are much less likely to get mental health services. It's really, so a lot of people either can't or don't want to access a specialty mental health service as well. And so we'll kind of talk through what are some of the barriers to that. This is just kind of showing you some numbers. There is both an issue with prevalence and an issue with accessing care. And so we've got just some examples here. 21% of adults in the US are experiencing mental illness, and then 15% of adults had a substance use disorder in the last year. Substance use, most of the time integrated behavioral health mostly just focuses on mental health or health behaviors rather than substance use, but some of the clinics that I've worked with actually do some substance use work and have medication assisted therapy and treatment and that kind of thing. But across the US, 93.5% of people with substance use disorders didn't get any kind of treatment this last year. And then 16% of youth report suffering at least one major depressive episode in the last year. Of adults, 55% received no treatment. Of youth, about 60% of youth with major depression did not receive mental health treatment. And then 28% of all adults with mental illness reported they were not able to receive treatment that they needed. So this isn't just a matter of like, people don't know that they need help, but when they even try to reach out, they can't get it. It's really difficult. And so this is just another example from the Kaiser Family Foundation of this last year, women ages 18 to 64. This is, so the whole chunk here is women who thought they needed mental health care. So this is like that group of people who should be getting services. And only half of them were actually able to get services. 10% of them tried it, didn't get it, and then 40% of them didn't try, even though they knew they needed it. So why do people not actually seek care if they know that they need it? There are a lot of barriers to seeking care in the US. This chart kind of shows you from the top to the bottom. On the left side, you can see deciding to seek help and then accessing help. So you've got kind of this continuum of like, at the top, you have people who decided like, okay, I need some kind of mental health services, but my family circumstances or responsibilities are getting in the way. Maybe they don't have the ability to take the time off work. They don't get sick time or something like that, or they have little kids and they don't have money to pay for a babysitter. So they can't, they can't just show up to their therapist's office and leave the kids in the lobby or something like that. There's a lot of time and effort that are involved. And so you have to be able to call around, you have to be able to spend time doing all this paperwork that's like intake paperwork and all that kind of thing. And so once we get down to kind of this middle, then you also have attitudes towards service providers and treatment. In the US, mental health is still really stigmatized. A lot of people don't want to seek services because they are concerned that they'll be looked down on or thought differently of, or maybe they've had bad experiences with providers in the past and they're kind of reluctant to reach out again because they've had difficulties. Like for example, Dr. Shields' presentation last month, the difficulties that people have when they're hospitalized and mistreated, they might not want to seek treatment again. So you have dismissive or you have dismissive professionals. Then you have this kind of question of belief of whether treatment is actually going to work. There's a lot of variation in effectiveness of treatment, and then there's also a lot of variation in people's experience with effective treatment. And then you have, like I said, quality of service is also a piece of that. So then we have knowledge and understanding of the mental health problem, and then the help seeking process. It's really hard to find a therapist, and it's really hard to navigate the system. Dr. Adams' presentation a few months ago talked about how difficult it was to actually just get an intake appointment. at a mental health center. And I think it was like 19% of the calls actually resulted in an appointment, and a lot of those were even waitlisted. And then we have the mental health system itself. We have a shortage of mental health professionals. There's long wait times, there's location issues. So those all are issues that behavioral health clinicians in an integrated model are trying to address through increasing service locations to places where people are already going, reducing stigma by, somebody can just say, I'm going to the doctor. They don't have to say, I'm going to see a therapist, because they're in the same location. And so nobody in the waiting room knows if somebody's there to actually see the physician or nurse practitioner or the therapist, and that reduces people's discomfort. So lots of reasons why an integrated approach is attractive to people who are a little hesitant to reach the mental health system. So the other issue is that people are already going to their primary care providers for behavioral health. They up to half of people experiencing a behavioral health concern go to their primary care provider first, and then up to half of primary care visits actually have a behavioral health component. So you have both the patients wanting to have the services there, and you have the providers who maybe had a couple hours of training in their medical school experience. If they were lucky, maybe they had some more training in their residency, or if they sought it out. But a lot of primary care providers actually have little to no training in mental health services, and a lot of discomfort with that, and not knowing how to address it beyond just writing a prescription, which they might not feel comfortable doing if they don't have training. So the idea with integrated care is, why not just bring the behavioral health clinicians to where care is already occurring? All right, so integrated care is a great idea, right? And everybody should be doing it, but there's a lot of barriers. So when you think about the medical system, you think about the mental health training. If you have mental health training, you can think about that. But there's very different approaches to providing care. And it's kind of two different worlds, it's two different cultures. And so blending those two together can be challenging, and kind of getting to that point where each person understands the boundaries of their role, what their role entails, and respecting each other's parts that they play. That takes a lot of commitment and a lot of just time and working through. There's also a lot of patients and providers not understanding or valuing the model or not using it appropriately. And there is managing behavioral health clinician time and availability. So really everywhere that implements it kind of has to come up with their own mix of like, how do we cover this person's time? How do we pay for them, basically, right? We can't just have them sitting around all day waiting for somebody to be like, oh, hey, I need a behavioral health clinician. So there are a certain number of like scheduled appointments, and then they have to kind of balance that with availability for the providers, or if a patient is in crisis and needs to be seen right away. So there's a lot of kind of like negotiating that and jockeying for it. And some clinics are better able to manage that than others. There's also a piece of that too with differing in insurance reimbursements and policies, what's allowed to be billed and what's not, and different payer sources, and that varies based on state. It might even vary based on more local policies. And so then you also have limited training for this model of behavioral health care. I actually had a participant call earlier today, and we were talking about how the American Psychological Association actually has internships that are solely in integrated care clinics. But LCSWs, LMFTs, LPCs, most people who are pursuing those licensures, they don't really have access to this kind of training in their clinical programs. It's something that just you have to seek out, but everybody's really trained in this kind of specialty approach where you see a scheduled patient for 50 minutes and you bill the insurance, and then you see the next scheduled patient for 50 minutes and the next. And so coming into this type of this type of model without that kind of training makes it potentially a disconnect between not only their skills, but also their comfort and their ability to provide effective services. So they are learning on the job. They might have reduced fidelity if they don't really have a good director or experienced VHC that they're shadowing that can kind of show them how to do this and how to apply the skills that they learned in their training in order to be able to do it. And then there's also dissatisfaction with the work. Some people like to know what their day is going to look like. And when half your day is unscheduled and kind of constantly having this, oh, we need you here, oh, we need you here. Some people just don't really like that way of working. And they don't really understand what that looks like if they get into it, if that's not the training that they've experienced. Then there's also the need to change workflows. This is a pretty big effort for a clinic you're not just kind of hiring a person. Like you also have to consider, how do we get patients to them? How do we implement various screening procedures? How do we, where are they gonna be? Where is their office gonna be? Where is their desk gonna be? Are they gonna be with the providers? Are they gonna be, there's just kind of like all these logistics. And I talked about the financial viability. Some places that's easier than others. And then there's also kind of this question of patients who do need specialty care and transitioning them. Sometimes patients don't really like the idea of starting to see someone and then having to start over again with somebody else. So there's that kind of balancing patient needs with patient preferences. Space I talked about, behavioral health clinicians typically have like a 30-minute appointment, whereas physicians might have a 15 to 20-minute appointment. And so you have this mismatch between timing of which rooms they're going to be using, turnover, room turnover and that kind of thing. So that's another kind of piece of that workflow and that space. And then technology, a lot of electronic health record templates that are used in medical settings are not necessarily structured well for a behavioral health provider to be putting in. And so there's kind of this either suboptimal charting ability, or sometimes they end up with two different EHRs, which is then difficult because you either have to log into two different systems in order to be able to see the other person's notes, or you just don't have access to the other person's notes unless they're like printed out and given to you or something like that. So that's just a small piece of the implementation barriers. There are more, but there are people who have overcome this. There are many, many practices with integrated care in our country. This is a small sample of them. The Collaborative Family Healthcare Association is kind of the professional home for integrated care professionals, both behavioral health clinicians and primary care providers who are working within this model and really interested in kind of continuing their education around it. And so this is where some of the member clinics are located. I know for a fact that there are many, many more in this country than what's on here, because there's only like 3 in Minnesota, and that's where I did my dissertation, and there was like 75 clinics in my dissertation that had integrated services. So, and then in Missouri, I know of many more here in the state as well that aren't on this map. So, so there are actually quite a bit. And that brings me to the reason for my study. So let's talk a little bit about implementation strategies first. Dr. Powell, who's the co-director of our center, and Dr. Proctor, who was the founding director of our center, are two eminent scholars in the field of implementation science. And 2 of their papers that are relevant for this discussion is so the ERIC project, which is Expert Recommendations for Implementing Change. And this is basically a huge list of like 73 different implementation strategies. So these are things that you can do in order to get something up and running, basically. So they include anything from starting new clinical teams to paying people to do certain things to getting services on, so the insurances will pay for them, doing consultation, doing trainings. There's a huge list, obviously. That's what this article developed. And then the second article below is talking about so the initial list just kind of gave you a name and a really short description, and the second one is basically saying you need to be more specific with what exactly are you doing. So it's not enough to just say, oh, I'm conducting educational meetings, but how often are you conducting the meetings? Who are you conducting the meetings with? Who is the lead of the meetings? How long are the meetings going to go on for? What's the content of the meetings? Are you doing the meetings in conjunction with another strategy? And then tell us more details about that. And so those are the two kind of implementation strategy papers that are guiding that piece of this this study. So as I mentioned, there are many clinics and organizations across the country that already have implemented integrated behavioral health, and a lot of times in implementation science, we as researchers kind of have this tendency to think that nobody's ever done this thing before, and we have to be the ones to figure out, okay, what's the best way to implement this thing? And so we need to test these different strategies that we've come up with. But at least with integrated behavioral health, that's not true. There are many places that have done it, and so they figured out ways to implement. So why don't we ask them how they did it? And then the way that we can make that into research is we can look at how we can generalize those strategies, if we can generalize those strategies, and so we can kind of leverage the strategies that already were successful for other clinics to be able to use, instead of taking all 73 of these strategies in various combinations and just kind of, you know, oh, this is my hypothesis of why this might work this way. We know, so let's try actually ones that have already been used. So how did they overcome all those barriers? That's my question. And these are the three aims of my study. The first is to identify and categorize the implementation strategies that were used, and also relevant contextual factors. So as I mentioned, you know, let's say Clinic A and Clinic B have both implemented integrated behavioral health, but Clinic A is in a wealthy area of an urban city, and most of their patients have private insurance. And it's internal medicine, so it's all adults. And then you have Clinic B that's in this small rural town that where most of the patients are in poverty. It's a family medicine clinic, so it's a whole life spectrum, and most of the people who go there either have Medicaid or are uninsured. These are two very different clinics with two very different patient populations, and potential payer sources, and size of clinics. You know, the large urban one might have 30 providers. The small rural one might have 2 providers. And so there, you know, you have to kind of, when you're thinking about implementing, you always have to think about context. And that's another thing that implementation science has really brought up a lot over the years. And I think it's becoming even more of a focus, is like context is king. And you really have to not only think about what you're implementing, but also what is the context that you're implementing in. And strategies that would be successful in Clinic A might not be successful in Clinic B. So we need to take that in mind. And the second one is to evaluate the IBH implementation success. So the 3 implementation outcomes that I'm focused on are penetration, which is how much the behavioral health clinicians are doing in the clinic, how often they're being referred to by the providers, what percentage of the providers are referring to them. Is it all of them? Is it only half? That kind of thing. Then sustainability, how not only how long has this been going on for, but do they seem to have a sustainable model, not only financially, but also in terms of managing staff turnover and policy changes and things like that. Are they robust? And then fidelity is going back to that with the 6 different boxes and looking at the specifics of what exactly are they doing that they're calling integrated care. Because for a long time, clinics would just, like I said, just hire basically a behavioral health clinician. They'd have a little office at the end of the hall, or maybe on another floor of the building or something, and physicians or providers would refer to that therapist, then the therapist schedule gets full because they're just doing the traditional therapy approach, and then they can't take on new patients, and the same issue occurs with providers that were outside, that were at a different agency or something like that. And so that was called co-location. Some places still do that because they don't have the capacity to be able to implement integrated care, and it does overcome some of those barriers to people not seeking out mental health services. So it's not that it's not effective, it's just less effective than the kind of more integrated approach that we're talking about. And so thinking about the fidelity to that model, if they're going all the way, if they're really following all of those kind of constructs, implementing the processes and the structures. And then the third one is assessing the relationship between IBH implementation success and cancer screening rates, which kind of get like, oh, what, cancer? So one thing that I didn't put on here is that we're funded through the National Cancer Institute, and that is, this is a pilot through the 50 here at Washington University. It's called the Implementation Science Center for Cancer Control. Dr. Ross Brownson and Dr. Grant Holditz are the PIs on it, and they every year they've been funding pilot studies. Ours was one that was funded last year. And so the reason why we're looking at cancer screening rates is because people with mental health issues are about 20 years, their life expectancy is about 20 years less than people without a mental health issue. And that's a really big number. And there's lots of reasons for that. Cancer is not the only thing, but there are definitely discrepancies between people with mental health issues getting their regular cancer screenings and people without mental health issues getting the regular cancer screenings. So the idea is that if a clinic has integrated care and they have behavioral health clinicians available, they have kind of this model of talking about mental health and addressing mental health and helping people overcome barriers to achieving kind of whole person care, then they might actually be having better cancer screening rates for those patients. And so that's what we're hoping to look at. So what we are doing, the methods that we're using are, okay, I'll get into that in a little bit. So this is just kind of an overview of the study elements, just to kind of give you a sense of how everything's related. So we have implementation context, plus implementation strategies, leads to implementation success, and then hopefully clinical outcomes improvement. That's kind of the hypothesis. And then we're assessing the implementation context with qualitative data, as well as the implementation strategies. We have a couple surveys that I'll get into in a second, that's going to be looking at implementation success as well as the qualitative data. And then the clinical outcomes are quality reports for cancer screening. So for clinics that are federally qualified health centers, we can pull that from the universal data system that they are required to report to. And for clinics that aren't, we're going to be requesting certain reports. And so what methodology are we using? We are using what's called rapid ethnography. And what rapid ethnography is really just a more rapid way of doing ethnography, which ethnography is basically you go to a place, you're observing people in kind of a certain community or a certain kind of defined group. And the idea is that you're just kind of learning what is life like here, what are they doing, kind of like getting this full rich picture and understanding the group, understanding their processes. And rapid ethnography is often used in healthcare settings because medical providers don't have a lot of time, and you don't want to be in their way because they need to see patients. And so rapid ethnography is kind of this balance between getting this full, really big, deep understanding of something and kind of just having more of a focused research question that you're kind of targeting so that you aren't just spending months and months and months being in the clinic. And then months and months and months more analyzing. It's more targeted, it's more focused, and it's kind of built to kind of answer these specific questions in a more rapid fashion. And so our original plan was actually to go into 8 to 10 clinics. We would have had about 12 participants at this stage. I forgot to mention, yeah, okay, so we have completed 3 clinics from 2 different organizations, and we have 2 more organizations that have been recruited that we have started data collection on, with 3 to 4 additional clinics. So we'll end up with either 6 or 7 clinics from 4 organizations. We've also recruited significantly more participants per site than we anticipated. We've been doing kind of more talking with all kinds of people at the sites. So initially, we're planning to talk with kind of the behavioral health clinician, at least one medical provider, maybe a support person like an MA or a nurse, and then like a clinic administrator if we had one. We've ended up talking with multiple behavioral health clinicians, multiple medical providers, multiple MAs and nurses, and then pretty much anyone else that we can get our hands on at each clinic. So we've also been talking with chief operating officers and scheduling managers and those types of people, because they've come up as relevant, and so that we're just kind of following, you know, where the questions lead. And so what we've been doing is kind of we go into the clinic. Well, so first we I think my slide got up there. Let me find where. Yeah, okay. So I'm gonna go here and skip that because we're yeah, so first what we've been doing is we have a discussion with the director of behavioral health integration or something along those lines, that title, and then we have a formal interview with them after we've kind of gotten their commitment. We observe the clinic and we have informal interviews with the staff. Usually it's like 1 full day with 2 of us researchers. Sometimes we'll do more days if we need to. And then we also request permission to like take pictures of like flyers, or we have them email us documents afterwards that are like reports that they use, that kind of thing. And so we also then have follow-up interviews with other staff, like I mentioned, the chief operating officers or the scheduling managers that either aren't available or not on site sometimes. And then we follow up with a quantitative survey in Qualtrics. So that, go back. Those 2 surveys are the practice integration profile and the provider reported sustainment scale. So those are targeting, the practice integration profile is targeting the fidelity question, and the provider reported sustainment scale is targeting the sustainability question. We also just asked some very small demographics questions as well. And so the rest of the design, so why multiple clinics? So why are we targeting 8 to 10 clinics? Or in this case, I think we're probably going to reach saturation at 7 clinics. So why multiple clinics? And that's because we're doing a matrix multiple case study design, which is a design that Dr. Bo Kim developed and published on in 2020. And it's basically multiple case studies. So you take these clinics, and what we're doing is, because we're thinking about, okay, what implementation strategies were used and what the implementation context is, we can't just study one site, because that won't give us kind of that more generalizable information. And so we really need to study across multiple sites and then compare them against each other. And so this is a kind of a textbook way to do it. She has it all written out, and it's really great. So if you're ever considering kind of doing this type of study, I would recommend reading her paper and clutching it very closely. So the idea here is that you really distill the data down into the relevant information, and then you can kind of matrix them across each other and look at what are the similarities and what are the differences. So we are going to be getting to that point after we're done with all our data collection and analysis. All right, so let's get to analysis. I want to make sure I leave time for questions. So our analysis, we are primarily deductively coding, and that also helps with the rapid part of the rapid ethnography, because we aren't kind of having to develop codes along the way. We're using the ERIC strategy list, all 73 of them, and the cross-model framework constructs that we discussed, and then also PRISM, which is a determinants framework in implementation science that kind of lays out different contextual factors that you might want to consider. Then we also are adding additional codes. I think we've added probably 6 or 7 additional codes that as we started going through the analysis, we're like, we really need X. So for example, we actually have a code called negative example because we realize that there's a lot of times when people are talking about something that isn't happening. So like we don't have consultation between the behavioral health providers and the medical providers on a regular basis. That's something that's in the cross-model framework that's supposed to happen, but that's not happening. And that's really important to highlight. So we added that, and we just have a couple other ones as well. So social determinants of health is one that we added because that's a huge, that's a huge category, but we felt like we needed to be capturing it because our clinics are talking about it a lot. And then we're analyzing the linkages between the implementation strategies and the cross-model framework constructs and layering on, then we will be layering on relevant factors after the fact. So we're using the software called Deduce, which has this really cool co-occurrence table and which is really perfect for our questions, because what we're asking is, what implementation strategies are being used to implement what constructs in the cross-model framework? And so it basically cross that co-occurrence for you. And so it does all that work for us, which is great. And I do think there are other qualitative softwares that do that as well. Our methodology consultant uses Atlas, and she said that they have one in there as well. I'm not sure about other ones. So we're listing out all these construct linkages, and then we have a list. Our tables are the context codes and the co-occurrence between the context and the strategies and the cross-model framework constructs. And then we have a different one that's strategies and then for which cross-model framework constructs they were used. So I'm going to give you some examples of those so you can see what I'm talking about. The other piece that I didn't mention before is that we are part of that we wrote into our grant, and something that's really important to me is that we're actually reporting back to all the clinics. And so for each clinic, we're developing a clinic-specific report of what we found for that clinic. And then at the end of the study, when we've done the full analysis and done kind of the compare and contrast, we'll be providing a full study report back to the clinics that'll be kind of like a lay version of the manuscript that we'd be writing, and it'll say, these are all the strategies that were used with this cross-model construct. So if that clinic maybe was struggling with implementing that construct, maybe they can try to use these strategies. And with kind of that added piece of the context, knowing that this strategy has worked in the context in which you work, hopefully would increase the usefulness of that to them. And so this is site 1. I'm not going to read through all this because, like I said, we're low on time. But this is a list of their contextual strengths that we found during our ethnography, as well as what came out in the surveys. So I'll just read off a few. They had really great team communication. It was very routine. They had kind of this way of having the behavioral health and medical providers interacting with each other that was just kind of standardized. It was normalized. That was what they did. They had a lot of their employees talked about how they really had a lot of autonomy and initiative, and they were really supported by the management if they wanted to try something new. And so that was a really positive strength. And I think that really led to, they just had this really great kind of quality improvement culture. And I think it was because all the employees were really just supported in there wasn't this like, oh, you can't fail at this or whatever. So it was just like, oh, you have this great idea, let's try to make it happen. And some things, actually happened and were really successful. So then we also put in the report opportunities that we saw. They did not have one HR across all their departments. They had 2, and it was complicated to go back and forth. But they also had reasons why they had 2. And so our suggestion was to either use one, which they really wanted to do, or develop a smooth information flow between departments if they decided that they weren't going to go with the one HR, the way that they had information going back and forth. And within each of these opportunities in the report, I kind of listed out more actionable things that they could do, but I didn't be a lot. So I, you know, then there's things like hire more staff, like you should hire more people, which they did, obviously. And then one of the things that I thought was interesting was they really had no tracking of patients, and that's one of the big pieces of integrated care is that they weren't tracking outcomes, they weren't tracking if they were beyond what they were specifically required to report to the universal data system because they were an QHC. They didn't really track like, you know, did this patient get the care that they were supposed to get? And then what were their outcomes? They didn't really have that. And so that was a big weakness at this place. And it was something that the manager wanted to do, but they just hadn't gotten around to yet. Or it was complicated. They were just getting started on it when we were there, starting to figure out the reports from the HR. So this is the practice integration profile. Remember, it is checking the fidelity. And so you can see there's five subscales. And what I actually did was I broke it down by, they had multiple directors that responded to the survey. And so I actually broke those people out because most of the time they tracked pretty well with the other staff. But like you can see in the patient workflow subscale here, the directors were significantly below the rest of the staff. And so I wanted to highlight that for them as something that the directors do not feel like their patient workflows are working very well. And so I felt like that was really important for them to see. And we might not necessarily do that for every clinic. It kind of depends on if we can get all the directors to fill out the survey or not. But so then what we did was we did this extraction where we had looked at the linkages between what strategies were used for which cross-model framework construct. And then what I did was I actually found some pretty universal strategies that they used for almost every construct that they had implemented successfully. And so I pulled those out as something that they might really want to make sure they include moving forward if they're implementing something new. And then on the left side, those are there, and I provided them definitions of what these strategies are. And then on the right, there were ones that were about half. They used them like half or a little more than half of the time with various implementations. And so those were also something to consider. And then what we had was these strategies on the left were kind of matched to these processes or structures on the right, and they were pretty specific. And so that was kind of like, these are some things that you use that were successful, but maybe they're only for specific processes. And so then what we started to do, but paused on, was the strategy specification table that I talked about before, where we talked not only about this is the strategy they used, but who was doing it, what they were doing, and then related strategies. So we have name it, define it, specify it. So then we have the actor, the action target. I'm actually gonna go back for a second to show you guys the. So for example, we had remind clinicians was one strategy, and then the specific construct was that they had protective time to do outreach and follow-up as needed, which they were not doing very much of. And so the subcategory was, we decided to put the subcategory, this one, it doesn't really change a whole lot from the cross-model framework, but like, for example, the second one, measure desired outcomes of care and continuous monitoring. The specific process was administering the PHQ-9 to patients when it was due. And so we felt that we needed to have the subcategory to make it really specific and clear what exactly was being implemented. And then we have the definition here, and then we use quotes that we pulled, that we kind of extracted this specification information from. And so then you have the actor. So for for the protected time, the actor was management, and what were they doing? They were reminding clinicians to block their schedule. For the PHQ-9, it was management, and they had just started sending this huddle report every morning that was showing the MAs and the physicians what the patients for the day needed to have being done. And so then we have temporality here. So the reminding was as needed, and they were in sustainment. The management was kind of always doing this. To what effect? I don't know, but they were always doing it. And then the PHQ-9 one, they just started that week actually, and they were in kind of the preparation stage. So you can just kind of see like how you use that information. So next steps. These are our next steps. We gotta complete our data collection. We have to analyze our data, and then write all the reports. Same for the cross clinic pieces, and then we have to write our manuscripts and publish them in academic journals. And then we also, so kind of next steps in terms of where would this lead. There's kind of three studies that I have in mind. First, the main outcome of this is actually to develop an implementation guide that we can then test in clinics that haven't implemented IVH yet. We can basically hand them this guide with all these strategies and contextual factors and stuff and say, okay, go, and see what happens. And then there's several pieces. So pretty much all of the clinics that we're looking at are using the PCBH model, not the collaborative care model. Collaborative care is apparently not implemented in hardly any clinics in Missouri. It's much more prevalent kind of on the coast for some reason, which I won't get into, but they're pretty much all doing PCBH. And PCBH's evidence is not quite where it could be, and that's something that is kind of counted against it. And so Hunter et al. Did a systematic review that ended in 2016, and so I think that probably needs to be updated because there's been a huge increase in clinics that do PCBH and publishing on it. And then I also think that we could do a secondary data analysis with HR data warehouse data. In my new role that I'm going into, I will have access to a data warehouse that has patient records from an entire healthcare system, and actually with access to 2 different healthcare systems, and both of those healthcare systems have had clinics with integrated care. So I think that I could use that data to look at some specific research questions. So that is where I'm wanting to go. And I'm going to skip that. And then I had questions for you guys if you didn't have any questions for me. Here's my references, and thank you for your attendance and attention.
So questions from people in the audience as well as people in Zoom and all. I have one question. It's really interesting to see that the treatment to target patient registry working on those are the heart of integrated care. I wonder what are you finding in terms of our clinicians trained to work in that manner? Those are extremely important skills, and we really don't train those things.
Yeah, I mean, I think the idea of like measurement-based care is still pretty new.
Mm-hmm.
I know as a clinician, I was trained in knowing when patients are getting better and setting things like SMART goals, for treatment plans. So you can say, okay, so this person, this is their treatment goal, and where are they at in their progress for that. But that's all just in the the individual notes and everything. It's not it. Then you don't necessarily like extract that or do things proactively, like making sure that everybody's getting screeners and that kind of thing. That's kind of more like population health, and it's a pretty varied in the systems that we're working with. Some really have none and some have more, but like the one that I just spoke with today has kind of more process outcomes, but not necessarily like a treatment effectiveness outcomes.
Because I worry about people are calling, this is a branding, so there's a type of integrated care, but if you're not doing like the hard elements of this, then it's sort of like co-located, and they're doing something, but they're trying to integrate, but it's not really integrated. And but I think, and it's not easy, people are not trained in those type of things, so that's the other component that this is being implemented without the right training and supervision for them to really that on. So you need strategies how to then increase sort of that skill set for patients.
I think that's the biggest piece. And what I'm finding is that a lot of places are doing the work, but they're not like they're being true to the model of PCBH, which is kind of that warm handoff. I'm here for all the patients. I'm here for curbside consults with the providers and all that kind of stuff. Like they're really doing that work, but they're not analyzing its effect.
Yeah.
And I think that that's also kind of why the PCBH evidence isn't really there, because like collaborative care, that's all they do. Like they're measuring things all the time. Like that's part of it. Like that's the heart of the model. And so they have like hundreds of studies published showing their effectiveness because that's what they do.
Yeah.
But with PCBH, it's a lot more like, I'm here to see people. I'm not here to like run numbers.
Yeah.
And that's kind of like why
there's sometimes what doesn't get measured doesn't get done. So and they can tell a lot of people what it done. So I do want to be sensitive on time because it's 5 p.m. We can stay a little bit longer for I think. Is there any other questions? Yeah, we'll do one more. Yeah.
Oh, I have to question. Okay. So my first question is you mentioned so far you have like 40. Could you tell me a bit more about the demography, how diverse they are? Yeah. And the other one, I think you mentioned it, but I wanted to be clear whether that's what you meant. You said that they were not tracking. Yeah. And so in my mind, what I was going to ask you was that does integrated behavioral health include follow-up? Because I know that implementation is also looking at sustainability. And so with the tracking, does the tracking include follow-up? And if it does it mean that IBH include follow-up, but then they are not doing it?
Yeah, that's a good question. I'll answer the second one first. It is supposed to include follow-up for sure. Some places are doing that more systematically, and some places are doing that less systematically, and kind of just more on like a individual by individual basis. And so you get into this place where people drop off and then they're not getting reached back out to because they're not tracking it. So yeah. And that's what I think Dr. Cavassa was saying about what doesn't get measured doesn't get done. Then you're not actually having the effect on this. The first question, the demographics of the participants. I haven't run those numbers yet, but I can tell you just from my knowledge, I'd say it was about 60% white, 40% Black. They're all adults because they're all working in these clinics. I couldn't tell you the ages. And regarding gender, I would say it's probably 75% female, and then about 25% male. Or
this is the workforce.
Yeah, it's workforce.
So thank you everyone for your time. We will be back in next semester. Have a great summer. And thank you, Gretchen, for your time and for your presentation for everyone here.
Thank you
so
for
much.
coming.
All right.